All right, let's play medical detective for a minute. Imagine you're cross-examining a clinical researcher who is absolutely positive they found a definitive, undeniable link between a patient's habit and a deadly disease. They slide the data across the table, and honestly, the numbers look massive. But before we just blindly declare causality, we have to demand an absolute audit of the noise. Are we actually looking at a true cause and effect here, or is there some hidden third variable pulling the strings from the shadows? Well, welcome to the Explainer. Today, we're going to permanently demystify two notorious statistical stumbling blocks that completely distort how we interpret clinical data: confounding and effect modification. Now, these two concepts constantly trip up researchers, students, and seasoned clinicians alike. But by the end of this, you are going to know exactly how to crack the code. Here is our game plan for today. We'll move straight through our diagnostic funnel, starting with the distorted association, outlining the rules, running the diagnostic, and finishing up with a killer executional pearl. So let's jump right into Module 1, the distorted association. Whenever you see a crude statistical association in your data, you're immediately facing a 50-50 dilemma. I mean, it might be real, sure, or it might be a total illusion created by confounding. Think of a confounder as an external variable that influences both your exposure and your outcome. It essentially acts as a puppet master. It pulls the strings from the background, making it look like the exposure is causing the disease, when in reality, that hidden confounder is responsible for the whole shebang. Moving right along to Module 2, the rules of a confounder. You can't just point fingers at any random variable and accuse it of being a confounder. To truly incriminate it, the variable has to pass 3 incredibly strict structural rules. First, it has to be independently associated with the exposure. Second, it must be an independent risk factor for the outcome. And third, and honestly, this is absolutely crucial, it cannot be on the causal pathway between the exposure and the outcome. If it fails even one of these rules, it is not a confounder. Which brings us to a really dumb mistake that so many people make, assuming a variable is a confounder just because it's a risk factor. You've got to remember, if a factor like hypertension is merely a biological stepping stone between eating a high-sodium diet and suffering a stroke, it's actually a mediator. It's literally on the causal pathway. If you try to control for a mediator in your study, you're going to mistakenly erase the true effect of the sodium entirely. So, how do we actually stop a confounder from ruining our data? Well, official board exam guidelines highlight a primary strategy here, and that is careful matching. If you suspect age is a confounder, you simply match the participants in your case and control groups by age. By doing that, you evenly distribute the confounder and completely strip away its power to distort your results. Problem solved. Let's step into Module 3, the stratification diagnostic. Let's say you already have the data and you need to audit it. This is where we bring in stratification, which just means splitting the population into subgroups to stress test the numbers. And doing this reveals the other side of the coin: effect modification. Now, unlike confounding, effect modification gives us stratum-specific heterogeneity. That's a fancy way of saying the risk either spikes or drops dramatically depending on the specific subgroup you're looking at, all because that third variable is actually interacting biologically with the exposure. Which leads perfectly into Module 4, Nature versus Error. This is a massive conceptual shift, so stay with me. Confounding is basically a nuisance. It's an artificial glitch or error in your data distribution that you absolutely must control for, match for, or adjust away using multivariable regression. Effect modification, on the other hand, is a biological truth. It is a reality in nature. You don't hide it, you actively spotlight it. And that leads directly to our next huge mistake. Never, ever try to perform multivariable regression to quote-unquote adjust away effect modification. You literally cannot adjust away nature. Think about it. If a drug works entirely differently in men than it does in women, you don't just average those numbers out to hide the difference. You have to report those individual stratum-specific risks separately so clinicians know exactly how to treat the patient sitting in front of them. Okay. Let's put this into practice with Module 5, Variable Discrimination Scenarios. We're going to apply our stratification diagnostic to a real-world setup. Imagine a retrospective study finds a solid link between drinking alcohol and lung cancer. The clinical researcher confidently claims, look, alcohol causes lung cancer. But, knowing that people who drink at bars are also highly likely to smoke, we decide to demand an audit. We stratify the patients into 2 distinct subgroups: smokers and non-smokers. Now, before we split the data, the unadjusted crude odds ratio is 2.5. It's totally statistically significant. On the surface, this looks like a huge risk, right? It strongly suggests alcohol drastically increases your chance of getting lung cancer. But watch what happens. Notice the mathematical signature here. The exact second we separate the groups, the association completely vanishes. Among just the smokers, the odds ratio drops to 1.02. Among just the non-smokers, it drops to 1.01. Both are trending right to the null value of 1.0. The risk completely evaporated across all strata. What does that prove? Pure confounding. Smoking was the puppet master all along. All right, let's pivot to scenario B. In this clinical trial, we're testing a brand new weight loss medication to see if it increases the risk of deep vein thrombosis, or blood clots. Since DVT has known genetic risk factors, the researchers smartly stratify the patients based on whether or not they possess a specific genetic mutation called factor V Leiden. If we look at the whole population combined, the overall crude analysis shows a really boring, non-significant elevation in risk. We're talking a crude relative risk of just 1.2. Honestly, if you stop looking right here, you would assume the drug was perfectly safe for pretty much everybody. But hold on, look at this stratification. Among patients without the mutation, the relative risk is 1.0, totally completely safe. But among patients carrying that factor V Leiden mutation, the risk skyrockets to 4.8. The medication is interacting biologically with the mutation to create a massive risk spike in one very specific group. That is stratum-specific heterogeneity in action, confirming effects modification. We absolutely have to report this so doctors know better than to prescribe this drug to those genetic carriers. Finally, let's wrap this all up with Module 6, the executional pearl. This right here is your ultimate cheat code for board exams or just critically reading medical journals. Don't overthink it, just scan the numbers. If the stratum numbers equal each other but differ completely from the crude overall number, say the crude is 2.0 but strata 1 and 2 are both 1.1, boom, it's confounding. But if the strata are radically different from each other, like a 4.5 versus a 1.0, it's effect modification. It really is just that simple. So, the next time you see a massive statistical association making flashy headlines, or some researcher tries to convince you of a crude claim, I want you to ask yourself, what third variable is hiding in the shadows? Are you looking at a true biological reality, or is it just a trick of the data? Keep that forensic mindset incredibly sharp. Always demand an audit of the noise, and I'll see you in the next explainer.